Hi, my name's Richard Bristow. I'm one of the vets at Pinkham Equine, and I'm going to give you a little talk on the lameness exam of the horse, including some of the conditions that we may find and treat. I'm going to endeavour to help you assess whether your horse is lame and explain how we assess and investigate lameness. Touch a little bit on the normal conditions of a joint and tendon and what happens when they can become damaged. Lameness can present in a variety of forms. It can be particularly obvious, as in this case of a horse with a foot abscess in its left forefoot, pointing the foot out in front of it, rocking back onto its hindquarters to try and redistribute its weight behind, or it can be subtle, as in the case of a horse with poor performance, which may be knocking down poles which it didn't used to knock down, or it may be incapable of performing certain movements in the dressage arena which it has previously been able to perform with ease, or it could just be a horse which has been purchased which is not performing to the expected level. So the first question is, how do I know if my horse is lame? When we are assessing a horse with a suspected forelimb lameness, the most straightforward approach is to observe what the horse is doing with its head. A horse's head and neck weighs a not inconsiderable amount, and when the lame leg is in contact with the ground, the horse will seek to lift its head and neck up to try and reduce the amount of load passing through the painful leg. Consequently, when the sound leg is in contact with the ground, then the horse tends to relax and will lower its head and neck. And this gives you the stereotypical nodding horse with a forelimb lameness. Conversely, when we are looking at a horse with a hind limb lameness, we're obviously focusing on the back end rather than on the head end. It is possible to get some head movement associated with hind limb lamenesses, but primarily we are looking at the pelvis. So when we're watching the horse trot away from us, it's simple to imagine a straight line running through the horse's tail that divides the horse into two halves, and then we compare the amount of movement on the left side of the line with the amount of movement on the right side of the line and see whether the two are even. When we're looking at the horse on the lunge, we will be also looking at the top of the pelvis to assess the range of movement. Obviously, as the horse is going round on a circle, the body will be tilted inwards, so it's hard to make a direct comparison comparing the inside with the outside leg. What you need to do is fix in your memory the amount of movement on the inside and outside legs on the left rein, and then switch the horse onto the other rein and compare and contrast. We're also at this stage be assessing the carriage of the legs, so how quickly does the horse carry its leg through in the flight phase. We're also looking at stride length and whether the horse is catching the toe, and several other subtle things that you can observe about horses' movement both in front and behind. So let's look at the subtle lameness. Sue Dyson, who is a vet up at the Animal Health Trust just outside Newmarket, undertook a study in 2016 where 57 sports horses which were deemed to be sound by their owners and riders were assessed by her. Of those sound horses, 73% were found to have some form of lameness or to have pain-related gait abnormalities, which were observed after thorough lameness assessment, including trotting in a straight line, lunging on firm and soft surfaces. 47% of those horses were lame under the saddle, and most importantly, I think, 12% were only lame under the saddle. So that's 12% of horses were sound when they were trotted, were sound when they were subject to flexion tests, were sound when they were assessed on the lunge on a firm and soft surface, but did then present as lame when they were ridden. The conclusions that we can draw from this study are that the riders were not detecting the lameness that was present in their horse. And lameness can manifest either as a subtle lameness that's not detectable by a rider, but may be observable from the ground in by means of sort of visually observable gait abnormalities, or it may be observable as a sort of a behavioural change which we may previously not have attributed to the horse being in pain. I think it's worth just reminding ourselves briefly what we mean by poor performance. Poor performance can cover essentially any horse which isn't performing to the level to which its owner would hope or expect. Obviously that can include the symptoms or behaviours that we can see listed on this slide. But it can also include certain other more subtle behaviours, which we'll talk about on the next slide. So there's something called an ethogram for the ridden horse. An ethogram is a catalogue of behaviours which are considered normal and abnormal for a horse when ridden. And some of the abnormal behaviours are believed to be indicative of discomfort. I've listed some of them here, some which you may be familiar with, such as when the horse is in canter, it may strike off on the wrong leg, or it may start cantering on the correct leg but then change onto the wrong lead. Also, you can get spontaneous gait changes in the front legs. So a horse which you're trying to trot may find it easier to go into canter. The hind limbs may not track up effectively. You can get the tail swishing, subtle changes in facial expression, and it's particularly evident changes in head position are particularly associated with horses that are subsequently shown to be lame or in discomfort. So that can be the horse moving its head from sort of in front or behind the vertical, or altering the angle in which it's carrying it, turning it from sort of one side to another, head tilting. All of these are constant changes in head position are associated with sort of poor performance and discomfort. I think the message which I would encourage you to take home from this part of the talk is that subtle behavioural changes that we may previously have attributed to a reluctance to be trained may in fact indicate discomfort. So it may be that your horse, which is misbehaving, being slightly difficult, is not in fact being bloody-minded or difficult to irritate you. It may in fact be exhibiting some sort of subtle indications of lameness or poor performance issue. And I think it's worth remembering that horses have spent millions of years evolving into a creature which endeavours to hide its vulnerabilities as a prey species in order to avoid being targeted by predators. And as a result, that obviously makes it slightly tricky to try and determine when the horse is suffering from lameness or pain, because it's doing its level best to demonstrate that it's 100% fine and there's no problems at all. So it is a little bit challenging in this area. So we've determined that your horse may well be lame. What should we do next? It's very simple. Keep calm and call the vet. This is just a brief list of the different stages of a lameness workup, beginning with the history that we'll take from the owner of the horse, detailing what the problem is in their opinion, how long it's been going on, etc., etc. The physical examination, so looking at the horse at rest. The dynamic examination, so seeing the horse move, trotting up, lunging, flexion tests, ridden, and then moving on to regional analgesia, so that's use of nerve or joint blocks to localize the lameness, followed by imaging, ultrasound, or radiography typically, can become MRI scans or scintigraphy if required, and then hopefully subsequently a diagnosis and treatment of whatever issue we have found. So when the horse is being assessed at rest, we will start with a visual examination. So we're looking at the horse's conformation, we're looking at its muscle mass. Are there any obvious weak conformational points? Is the muscle mass even from one side to the other? Or are there areas that indicate sort of lack of use? We'll then also move on to palpating the leg, observing the response to hoof testers and observing the response to kind of passive flexion of the limbs. And sort of during this time, we'll often be, carrying out the history at the same time, so discussing with the owner their opinion of the problem, its duration, the symptoms, and so on and so forth. So palpating the leg is exactly what it sounds like. We'll feel the leg in the standing position, weight-bearing position, and we'll also pick the leg up and feel the different structures when they're relaxed and with the leg held up. In order to do this effectively, it's really important that we have a thorough knowledge of the anatomy of the horse's leg. I've indicated a couple of areas that are clearly obvious on this thoroughbred's leg. So marked by the yellow arrows, we have a part of the suspensory ligament. The blue arrow is marking one of the pouches of the fetlock joint, and the red arrow is indicating where we would palpate for the coffin joint fusion. Essentially, we are feeling for signs of inflammation, so that's pain in response to some gentle sort of digital pressure, swelling, that can be quite subtle. But you're looking to see whether those structures you're palpating are any larger than you would normally expect them to be. Is there any heat? And is there any loss of function? That really kind of incorporates lameness, that comes later. It's important and helpful to remember in the horse that you have another identical leg, hopefully immediately adjacent to the first one. If you don't, obviously there's a small problem. But if you do, then you can use that other leg to compare and contrast what you're finding in the first leg, and see whether any abnormalities you observe in the first leg are there and present in the second leg, which may indicate that they are kind of normal for that horse, or may be indicative of a problem in both limbs. So here we see the application of a pair of hoof testers, which are tools that are used to just put pressure through the hoof and the sole of the foot to identify any localized areas of pain or bruising within the foot. It's important to put pressure across all the areas of the horse's foot, so the toe, the quarter, the frog and the heel, and to do it consistently and evenly in all four legs, in all 4 feet, so that you can identify what a normal response is for that horse, and hopefully identify whether there are any abnormal areas or not. It's also important to remember that different species of horse will react differently, so it's very easy to elicit a painful response in a thoroughbred with sort of thin soles, and that may not be a painful response that indicates the problem. It's just that the horse has thin soles and it's easy to pinch them and make them painful. Compared to that would be a sort of a warm blood or a cob with sort of slightly thicker, heavier feet, which would be sort of much harder to get a painful response in. The dynamic assessment. Here we see Beth leading her horse Craig up and down. She's giving a good example of how to trot a horse away and back. In a straight line, she's giving his head plenty of room to move. We're trotting on a firm, level, non-slippery surface. She's moving at a consistent speed and pace. So yeah, that's a nice example of how we like to see a horse trotted up. Here there are some still images of me performing some flexion tests, forelimb and hind limb. And flexion tests are obviously everyone's favourite part of the examination, particularly in a vetting. But in all honesty, they do form a useful part of the lameness examination. They are not the be-all and end-all. They can indicate and help you localise areas of pain, and equally sometimes they can be misleading. And you can get a sort of a response to a lower limb flexion test that would suggest that there's a source of lameness in that area, and subsequently you can block the horse up the leg and find that actually the lameness was coming from much higher up the leg than you would have expected. So I think it's important to perform them on all the legs, not just the leg which you are suspicious upon, but all the legs of the horse, so that you get a clear idea of that horse's behaviour in response to kind of flexion tests in the normal and abnormal limb, and to be consistent, so hold them up for the same amount of time, apply the same amount of pressure, and to do that across all the horses that you see. Because this enables me to build up a sort of a mental library, if you like, of normal and abnormal responses to flexion tests in a variety of different horses with a variety of different conditions. When we're lunging the horse, touched upon earlier, observing for fore and hind limb lameness, so head carriage, head movement up and down, stride length of both the forelimbs and the hind limbs. Is the horse catching its toe, dragging at all? Range of motion on the pelvis. Is the horse swinging its back? Is the horse, when it's on a circle, looking inwards? So if it's on the left rein, is it sort of head and neck turning to the left as it's going around the circle? Or is it shifting its head out to the right side of the circle, which may be an attempt to avoid or try and reduce the amount of weight it's carrying on its inside leg, or it could just simply be that it's seen something interesting in the next door field. You have to bear in mind all possibilities. Finally, the Ridden assessment. We don't always reach this stage, and certainly if a horse is visibly lame when we're trotting it up, or seeing it observing on the lunge, then it's not always necessary to see the horse ridden. But in those horses that don't show any lameness but do apparently have a problem, then it is useful to see that horse. It is useful to see that horse ridden, to see that horse doing its job, and as we sort of remind ourselves from earlier, there is a sort of a small but significant proportion of horses that are lame and will only show that lameness when they are ridden. So once we've identified a consistent lameness, we will then seek to localise it. If there's a particularly swollen or painful looking joint, then we may jump straight to joint blocking that joint in an attempt to sort of shortcut the lameness process, and sort of get a quick answer as to whether that is the painful region or not. More commonly, the indications of sort of pain and swelling are more subtle, and with us would go down the route of nerve blocks. Typically we would obviously start at the bottom of the limb with palm digital nerve block down here in the foot. It's marked by the yellow arrow, the yellow circle. That will numb out the heel and sole of the foot. If that doesn't eliminate the lameness, we can then move up the leg to perform an abaxial sesamoid at the base of the fetlock joint, which will anaesthetise in addition to the sole and heel of the foot. That would then anaesthetise all of the foot and the pastern, and thus we can sequentially move up the leg, gradually increasing the amount of the areas of the leg that are numbed out, and by observing the horse to move after each nerve block, we can assess whether we've altered, decreased, worsened in some cases the lameness, and thus we can hope to localise it to a specific point, which will thus enable us to then investigate it further. Here we've got a diagram of a healthy and an unhealthy joint. And I thought it would be useful just to have a very brief recap on the commonest cause of lameness in the horse, which is degenerative joint disease, or DJD. In a healthy joint is composed of two bones, typically held in opposition to each other by the joint capsule. The ends of the bones are covered with smooth cartilage, and between the bones, between the cartilage, is a layer of synovial fluid, which is produced by the inner layer of the joint capsule. You also have collateral ligaments that help to stabilise the joint and prevent it dislocating. So when that functions well, it functions very well. When it gets damaged, that function effectiveness decreases. Chemicals, cytokines, destructive enzymes are released into the joint fluid. They actually serve to degrade the joint fluid. Healthy joint fluid has three main functions. It's a lubricant, it's a shock absorber, and it helps to nourish the cartilage. When it gets attacked by these enzymes that are released into an inflamed joint, then it becomes thinner, becomes more watery, it loses its ability to lubricate as well, and it loses its ability to act as a shock absorber. This means that the cartilage becomes subject to more wear and tear, and eventually, if that inflammation is not arrested, halted, improved, then the cartilage will become more worn, it will become thinner, the joint will become less stable, and eventually you'll get the formation of osteoarthritic changes around the joint, which comprises kind of new bone in the form of osteophytes. In addition to joint problems, the other another common cause of lameness in the horse would be soft tissue injuries, and that would be injuries to the tendons and ligaments. Typically, in this case, I'm going to just outline a tendon injury. So tendons are made up of many fibrils, which, when placed together, form a strong and sort of elastic structure, which transmits the forces generated by the muscles near the top of the leg to the lower limb and helps propel the leg forwards, the horse forwards. And when a tendon is damaged, then those fibrils will often pull apart, and you'll get bleeding into the area where they have been separated, and that gives you this this characteristic bowed appearance on the back of this horse's left forelimb. The tendon is obviously grossly swollen and will be hot and painful to the touch. And this is obviously a condition which we would assess ultrasonographically, which I will touch on shortly. Having localized a lameness to a particular region of the horse's leg, we will then image it. In this case, we're using radiography to look at the bony or skeletal components of the horse's leg. And yes, essentially you're taking a number of different views of the joints within the horse's leg, or the joint that you're suspicious of, and then you're looking for any abnormalities. In this case, we have a horse which has, as a young horse, with a swollen stifle joint, and it has a bone chip. This is a developmental condition rather than a wear and tear condition called OCD. This is something that has risen as the horse has developed, from sort of foal into sort of 18 months old or thereabouts. And what typically happens is you have a little bit of detachment of bone and some associated cartilage, and that can float around and cause inflammation within the joint unless it's removed. In this slide we have two joints, a hock on the left and a fetlock on the right, which are both actually from the same horse, a 20-year-old hunt horse. No discussion about lameness and poor performance would be complete without at least briefly mentioning the pack. The back is more commonly found to be painful as a result of fore or hind limb lameness, but can occasionally be a primary source of pain. In this particular horse, we have a severe case of kissing spines. You can see that the spinous processes, which should have a gap in between each one, are all sort of overridden and contacting each other, and we can see by the changes in bone density these patches of brighter white bone where the bone is more dense, and these sort of circular darker areas where the bone is less dense. These are indications that this is a sort of an active, ongoing problem. The bone is very active and likely to be quite painful, and this is quite a bad case of kissing spines. In this slide, we can see some commonly used joint treatments for the horse. On the left of the slide, we have corticosteroids, which are a potent anti-inflammatory, and when used in an inflamed joint, they can be extremely effective at reducing the inflammation that's present. They must be used judiciously. If given too often, they can end up causing the cartilage in the joint to thin, and you can end up shortening the horse's career rather than prolonging it. And if given in too higher dose, then it's believed that they can cause laminitis to occur. So obviously, to avoid that, we ensure that we remain below what is considered to be a safe dose rate. In the middle of the slide, we can see Synvet 50 and Hyaenate. These are formulations of hyaluronic acid. Hyaluronic acid is a component of joint or synovial fluid, and it's the component that gets degraded quickly when the synovial fluid is inflamed, and that causes the fluid to lose its lubrication and shock absorbing abilities. And so when we inject a joint with steroids, we will frequently add in some hyaluronic acid as well to try and restore those that synovial fluid to its healthy status as quickly as possible. On the right side of the slide is a picture of a ProStride kit. ProStride is a form of regenerative medicine, and I'll go into detail about regenerative medicine on a different occasion, but suffice to say it's a branch of medicine that involves taking blood or occasionally stem cells from the horse's body, processing it, and then re-injecting it into the horse, be that into a joint or into a sort of an inflamed or damaged ligament or tendon, in a bid to encourage more effective healing and restoration of function. It's a branch of medicine that is sort of comparatively in its infancy compared to some other areas, but certainly it's an area that we're very interested in, and we've used our ProStride kits on a number of occasions and with good results. So it's definitely there and available for use in sort of appropriate cases. I felt it was worth just touching on joint supplements, seeing as we are discussing joint treatments. Joint supplements are never going to be the be-all or end-all, and they're never going to prevent a horse from suffering lameness over the course of its career. But I think if you choose a high-quality supplement that contains those products, ingredients such as chondroitin, glucosamine, hyaluronic acid, possibly MSM, those ingredients which have been demonstrated in sort of studies to have a beneficial effect on joint health, then joint supplements can help to elongate the period of soundness that your horse can have, and it can certainly help to elongate the interval between joint treatments. But I do think it's important to stress that you should do your homework, you should talk to your vet, you should choose a supplement from a reputable company that rigorously controls what goes into its supplements. There have been a number of high-profile positive drug tests in the horse world, which have come from contaminated feedstuffs, and it's not unknown for amateurs to be drug tested at one-day events in this country, also at dressage competitions. So you do have to be responsible for what you're putting into your horse, and that includes joint supplements as well as more commonly used drugs. The other imaging modality that we would use most frequently on a yard would be ultrasonography. Ultrasonography is great for assessing the health on soft tissue structures, so tendons and ligaments primarily. In this example, we can see a superficial flexor tendon over here, which has received some damage on the palmar margin. The ultrasound enables us to determine how badly this tendon has been damaged, what area in percentage-wise has been damaged, and also how far in length terms that damage extends sort of up and down the leg. And by knowing the degree of the damage, that enables us to advise on whether the horse is likely to be able to return to work in the future, and it enables us to advise how best to help the horse on that pathway, and that can be by use of certain medications which can be injected into a damaged tendon or ligament, and also it's by use of the correct sort of rehab process, so controlled exercise, box rest, cold hosing, water treadmills, shockwave. There are many different ways to encourage a soft tissue injury to restore and repair. Obviously, time is probably one of the most important components. As injuries of this nature will take sort of between 9 and 12 months to repair fully, if not longer on some occasions. So by ultrasounding the leg, we are able to guide and follow the process of repair, and advise sort of on different levels of exercise, different treatments at different stages during that repair. I won't go into any more detail on tendon repair than that at the moment, because otherwise we would be here all night. So thank you for listening. I hope it's been informative. I hope you've enjoyed it. And if you have any queries or want to follow up on anything, then please don't hesitate to get in touch with me at the practice. Thanks.